The next instruction course, and that is how to predict and reduce post-LASIK ectasia, current concepts and technologies. So basically it is about the post-LASIK ectasia is after the LASIK, and we are trying to comprehensively discuss the causes and the management and the current status of that situation. So I have with me my co-instructor Dr. Rishi Mohan, and then we have Dr. Bhupesh Singh and Dr. Purendra Bhasin. They will be joining us shortly. So my talk is the first, and that is the interpretation of risk factors, the PTA. That has come as a new concept about percentage of tissue ablation, and I've been practicing this percentage of tissue ablation since very early time when I started with the mechanical system, the ALK, automated lamellar keratoplasty, which was a microkeratome where you could vary the thickness of the flap as well as the thickness of the central cut, so to correct a myopia ranging from -2 diopter to -20 diopters. So and we understood that the minimum bed which you should leave is 50% of the total corneal thickness, because we understood that a minimum corneal thickness which is required to keep the cornea stable was at least 50%, and that practice I've been doing for more than 30 years, because we got our ALK system very early in my practice, which is now 37 years old. And I can tell you that even after correcting very high myopia with automated lamellar keratoplasty, where we use a Chiron Technolas system to correct the myopia with the microkeratome, I did not get a single case of ectasia in initial time. So this practice of leaving 50% of the corneal bed is something which I can vouch upon, which I can say that it is the best technique or best practice where you will not have ectasia. Later on, there were issues like what is the corneal, how the corneal ectasia happens in the cases where there was sufficient corneal bed was there, like 300 microns and whatever, and people tried to zero it down to a corneal thickness, residual corneal thickness of, some people said 250 is the minimum, and others said it is 300 microns which is necessary so that there is no ectasia. But I can tell you that 50% of the bed was most important when we thought of corneal ectasia in all these cases. Like a 300 micron was sufficient for a 600 micron cornea, and 250 micron was good for a 500 micron cornea. So that the fundamental thing was that there was a tissue required according to the original thickness of the cornea, and this is what I'm going to talk about. So corneal ectasia after laser in situ keratomiliosis or LASIK is a complication characterized by progressive corneal thinning and bulging, which all of us understand, and it causes significant visual loss. And while most patients who develop post-LASIK corneal ectasia present with identifiable risk factors, especially pre-operative changes on corneal topography or tomography with a Scheimpflug camera, ectasia is present in normal in cases where the preoperative tests were normal and they developed ectasia. So this is a mystery, and that is where all these studies which came into and resulted into this PTA concept has developed into a sure shot prevention of ectasia possibility. First few recognized reports were published by Seiler in 1998. There is described case reports of patients after LASIK with progression of myopia and rapid progression of central steepening, which they classified as keratectasia. 50% of cases presented keratectasia in first year, and 80% in the first 2 years of their undergoing a LASIK procedure. It is more prevalent in males, and younger, higher myopes and thinner corneas are, of course, well known facts. Roberts and Dupp suggested that a biomechanical modification after LASIK is focal in nature, and it went into a situation whereby we realized that biomechanical strengths of keratoconus cornea with brilliant microscopy also found that mechanical loss was focal, primarily concentrated within the area of the cone. So focal reduction in elastic modulus resulted in biomechanical decompensation, initiating a cycle of increased stress, redistribution, and subsequent focal steepening and thinning, and this was actually leading to ectasias. So TEM, or transmission electron microscopy, it showed that there is epithelial hypoplasia and hyperplasia in different areas of ectasia, and there was Bowman membrane breaks and hypocellular stromal scarring, and also in these cases there were thinned residual stromal beds. Artifactually, larger interlamellar clefts within the ectatic regions, so that there was more spacing in the interlamellar fibers, and thinning and loss of rigidity in stress-bearing regions of the stroma. Both interlamellar and subsequent interfibrillar slippage contributing to the chronic biomechanical failure in ectasia after LASIK. A nearly identical biomechanical failure is seen in keratoconus. So what we were producing surgically was like whatever is happening in keratoconus in the normal individuals because of their genetic predisposition. So the risk factors were too thin or irregular corneas. I'll stop and welcome Dr. Purendra Bhasin, our co-instructor. Please come on the dais, Dr. Purendra. The larger pupils, higher refractive errors, the unstable vision, which is a major contributing factor, and we realized that we have to wait for vision and power to stabilize for at least 1 year before taking the patient for laser vision correction. Dry eye was another factor. Age, smaller age is a bigger factor in causing ectasias in these patients, and degenerative or active autoimmune disorders were one factor which caused ectasias in all these patients. So the idea from where we got this idea that how to investigate for the ectasia, we realized that we reviewed the retrospective cases, and with review of the retrospective cases, there was diagnostic and surgical skill improvement, screening criteria evolved, and residual stromal bed thickness was given sufficient importance, and topographic abnormalities, where there is a topographic abnormality, there is a possibility of ectasias post-operatively, like thin corneas and thick flaps were another factor which led to the ectasias. So the more important thing was how to continue and do the basic investigations so that we understand the corneal biomechanics and corneal weakness, possibility of weakness was, we realized that keratometry when it is more than 46, or oblique cylinder, astigmatism, a thinner pachymetry. The importance of posterior surface elevation came with this knowledge when we started doing the corneal profile measurement, and inferior to superior corneal power relationship, and posterior best fit square surface was the most posterior best fit sphere That was the factor. When we took all these factors into consideration, then we realized that there are some things which are important, and then we can go ahead and predict as to whether this cornea is weak or not. Additional risk factors was smaller age, asymmetry between two eyes. Like if one eye has a astigmatism at 180 degree and the other has 90 degrees, like with the rule astigmatism and against the rule astigmatism in two eyes, and this mostly this was progressing towards PMD or form first keratoconus. And also in cases where we did enhancement by lifting the flap, thereby reducing the residual stromal bed. That was another factor which took us towards the ectasia at a later point in time. There was this ectasia risk score where the points were given to as to what is the original topography, shape or residual stromal bed, like less than 240 to more than 300, or age 18 or less, and then pachymetry less than 450 microns, and the mean spherical equivalent, like in cases where the power was more than 14 diopters, to anything which was 0, like the power was less than 8 diopters, where the ectasias were seen rarely. These factors, the ectasia risk score, also went in a long way of Government of India giving guidelines as to where the ectasia is possible, and the LASIK guidelines came into picture in the year 2003, where we realized that all these cases, the ectasia is more commonly possible or more commonly seen, and the Ministry of Health gave us a guideline, and that is very important. And you must, all of you must read those guidelines before you undertake to taking patients for LASIK, because those guidelines are there and they are valid for the law, if the case goes in court. The corneal tensile strength is significantly higher in anterior 40%, where we are doing the majority of flap making and laser correction. So laser flap contributes little to corneal tensile strength, and that is why it reduces the tensile strength. And a residual bed of single figure like 250 micron or 300 micron is not a valid figure, because this is not actually a factor which is seen more often, because sometimes a thicker corneal bed is again leads to ectasias in all these cases. So a variable which is 50% of PTA is very important. Percentage of tissue altered plays a significant role in causing post-LASIK ectasia, and it is a change of biomechanical integrity of the cornea which exceeds the threshold required to maintain its curvature. And in theory, this can happen in 3 different scenarios: when the cornea is already prone to developing ectasia, that we can understand by doing different tests, especially Pentacam or Galilei; when a weaker but clinically stable cornea is subjected to surgery without understanding the biomechanics; and relatively normal cornea is weakened by surgery exceeding its safety threshold, where we are removing more tissue than what is acceptable, and the percentage of tissue altered is higher than what it should have been. So the tensile strength of the cornea is not uniform throughout its central thickness, with progressive weakening of the posterior 2/3. This influences the degree of biomechanical impairment after refractive surgery, with flap thickness and ablation depth playing a significant role in postoperative weakness. We have proposed and investigated a new measure, PTA, which is better parameter to describe the postoperative effects on the cornea. This was the study by Santiago and al. And it was published in American Journal of Ophthalmology in 2014, where PTA is the flap thickness and ablation depth divided by central corneal thickness, and it should be more than 50%. So this is a significantly and scientifically validated risk factor, and even in a normal topography, if this PTA is more than 50%, sometimes we see ectasia. PTA especially above 40% and significantly associated with development of ectasia, and this we must take into consideration while doing the correction, as I said about the pupil size and the area of correction, everything. So these are few pentacam pictures where you see that this is despite the fact that it's a very steep cornea, we will not have a ectasia in all these cases. These are all normal cases, but where the K max is 47.7, we must red flag this kind of cornea, and we must be very careful about treating such corneas. And here there is a 4-map composite display: sagittal curvature, anterior and posterior elevation, and corneal thickness, and where we see the posterior curvature is significantly steeper, and these are the eyes which can lead to ectasias in all these cases. So this kind of eye should not be taken for the laser vision correction, especially the LASIK. And this is a bad display which everybody knows, whosoever is using a pentacam, that posterior float. Here you can see that there is a frank kind of form thrust or keratoconus possibility in this eye, and these should not be at all taken with the. And keratoconus is there in thick cornea also. There is a possibility. Here you can see this, the corneal thickness is sufficiently high, but still there is a possibility of keratoconus in this eye. So only a pachymetry reading is not sufficient. Rest of the factors are also important, and in these cases we should not touch the cornea at all. Thank you very much. So now we go forward, and I'll be inviting Dr. Rishi Mohan. He'll be talking on interpretation of biomechanical analysis. Biomechanical analysis. Yeah.
Where do we get those guidelines, Indian government guidelines?
Okay, it's on the Ministry of Health website, and as I said, this was in I think 2003 that we had a controversy regarding ectasia in laser, and I think if you go back, or yeah, that is the best way to get it. Yeah.
So is there any role of measuring, I am here, I am Purendra.
Sorry.
Role of measuring, checking the epithelial thickness in the
Actually, now we have understood that epithelial thickness is thinner in cases where the ectasia is seen in those eyes. So now the mapping of the epithelial thickness is becoming more and more important. And I think if you have any more information, you can pass it on to our audience.
I think we have to check the epithelial thickness also, like ASOCT we should look at, and we will find that normally the anterior segment epithelial thickness is around 50 to 60 microns in all the cases. But in the area where the suspicion of keratoconus is there, there is slightly thickening of the epithelium is there, which compensate with the thinning of the cornea, which is the compensation which occurs naturally. So that also we should look, and that is also an early sign which we can pick up by OCT. So OCT, yeah, more in the in cases where there is a suspicion of keratoconus, and ASOCT should be a part of our complete examination before the LASIK, along with the topography, which includes the posterior float. Topography like pentacam, which includes the posterior float of the cornea, this should be the mandatory examination to rule out any early keratoconus or former frusty keratoconus. Sir, sorry for interruption.